Welcome everyone to the March edition of the Trauma Webinar Series. My name is Bree. I'll be your moderator and kind of host today. We're lucky to be joined by Dr. Suzanne Salsman, an assistant professor and physician in the Division of Physical Medicine and Rehabilitation. Suzanne's going to tell you a little bit more about herself before she starts her presentation, so welcome.
Hi, and it's such a great opportunity to speak with Trauma Nova Scotia and Trauma New Brunswick today. Joining me is Dr. Monique MacFarlane Conrad, who's also a physiatrist, and you'll learn all about who we are. We both have some new roles within our group, so I think that this really speaks to our interest in education and research. Meeting with you today. I'm the research director for the Rehab program, and Dr. MacFarlane Conrad is going to be the director for our program starting April 1st, but taking off right now. So, so she'll have a big role in what the residents learn and do. So thank you again for having us. And today the talk is on trauma and rehabilitation, mobilizing ideas for collaboration to improve patient outcomes. The talk, although it's slides and appears formal, I'd appreciate if you have any questions to put them in the chat box. Dr. MacFarlane Conrad is going to be monitoring that. So if there's anything that kind of needs to be, answered based on maybe some information that I've put out, please go ahead, because we might as well answer it in the moment. So just moving my slides here, or not. Oh, there we go. Okay. To start off, just recognizing that Dalhousie University and the QE2 Sciences Center are located in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq, and we are all treaty people. Disclosures: we have nothing to disclose with regards to financial relationships. The objectives for today is, at the end of the session, learners will be able to describe the specialty of physical medicine and rehabilitation, also known as PM&R, the role of the PM&R physician and their scope of practice, identify patients meeting criteria for inpatient PM&R consultation, transfer to an inpatient rehabilitation facility or outpatient services, and describe strategies to improve recognition and management of common rehab emergencies, such as autonomic dysreflexia and spinal cord injury and agitation and traumatic brain injury. So to start off, the case that we'll be following through this is, as presented, a 58-year-old man involved in a motor vehicle polytrauma with multiple fractures, head injury. So the head injury itself is a small subdural hematoma. There's a number of fractures that have been addressed with orthopedic surgery, so X-fix, and also fixation of wrist and hip and femur and tib fib fractures. Also fractures of both shoulder blades and non-weight bearing status for both arms to let those heal without operative management, and a retroperitoneal bleed. So this gentleman is admitted to the ICU, and early mobilization is limited due to his agitation. So at post-admission day 7, transferred to orthopedics, and mobilization is still limited both by agitation and pain, as well as the non-weight bearing status to allow the shoulder blades to heal. As well, the therapists who are helping to mobilize him see decreased movement in his right leg. And overall, it seems like he's not going to progress any further on the orthopedic floor. So a referral is sent for review by physical medicine and rehabilitation. So what is physical medicine and rehabilitation? So this specialty evaluates and treats patients whose functional abilities have been impaired. This can be because of a congenital impairment. It can be because of something that has been acquired through life, through injury or progressive neurologic condition. And overall, no matter what people present with, if there is an impairment there, physiatrists and the team look to improve a person's functional capabilities by medical treatment on our end as the medical specialists, and also organizing with our team a program of rehabilitation therapy. So rehabilitation services are run through rehabilitation hospitals most often, and I can only really specifically speak to our experience here in Nova Scotia. So we work through the Nova Scotia Rehabilitation and Arthritis Centre. We have 66 inpatient beds for our various subspecialty services. And we also have outpatient ambulatory care with subspecialty clinics. And these often involve our interprofessional team. So both on the floor and in outpatient clinics, we have access to physiotherapy, occupational therapy, people who create prostheses, orthoses, our dysphagia team, assistive technology, and also our ABI outreach in the community. So we wouldn't be able to function without these team members and these resources. The subspecialties that we focus on are traumatic and acquired brain injury, spinal cord injury and disease, complex stroke, and by complex, I mean that they have significant impairments that require a integrated rehabilitation plan. Congenital and progressive neurologic disorders. So these can be multiple sclerosis, ALS, cerebral palsy, muscular dystrophies, as well our amputee program, musculoskeletal disease, which can be acute or chronic conditions, and spasticity management. Overall, again, no matter how someone presents, we use a physiatry lens in order to look at the impairments they present with, and then apply our knowledge and our teamwork to improve function and quality of life. So the different things I have listed here is pretty much par for the course for what the types of questions that I ask patients every day, whether in an inpatient or outpatient setting. And we're going to review these a bit further in the context of our case as we go on. So the other thing I wanted to talk about today was trauma rehabilitation, and I'll just go through this briefly, but it's become an interest for a number of reasons. One is that more patients are surviving critical illness, and this the graph that I have here is data from the United States, but it's also reflected in data that's come out of the United Kingdom and Australia, where patients overall are having more serious scores for disease, but are having less mortality. And this is because of technological advances in order to help save lives. Saving lives is great, and then after that, we know that somebody who's been through a significant critical illness has some lasting impairments, and long-term physical morbidity is common in persons surviving critical illness. So the other thing that highlighted the importance of trauma rehab was, of course, the recent COVID-19 pandemic. So post-COVID-19 rehabilitation became a hot topic. And this graphic is from a publication in Nature in 2021. And it looks at, it compares someone who has had a background disability. So say somebody who's had coronary artery disease. So over their life, their disability from that increases with age, but it tends to be over a longer period of time. The issue, of course, with COVID-19 or with critical illness is that you could have somebody who is healthy and they have this sudden impact to their health, and that return to their baseline is also complicated by other factors from that disease. So as a specialty, physical medicine rehab with regards to the COVID-19 rehab plan looked at the disease itself, the disability emerging from it, and also the distress that it caused to patients with regards to impact on their quality of life. Also looking at other other comorbidities that could have been present, perhaps how a patient might present as more frail prior to having a significant illness. And then overall challenges to participation, whether that's, and usually it is within a hospital setting with regards to mobility and activities of daily living. But another thing that's come out of the pandemic has been our awareness of how isolated our patients with physical disability became. And I think that it's changed our lens to look at challenges to participation in general in the community. So overall, the outcomes to address these things were patient-centered. And also looked at longitudinal healthcare needs. And I'm sure everybody's kind of aware, looking at the long COVID data that's been out over the last few years. So returning to the case, so after the consult went in, and this is in general with inpatient consultation, we need reports from the team that's treating this gentleman. So physiotherapy sends us their report, kind of up to date how he's doing with physical therapies, occupational therapy with regards to day-to-day activities and independence, and also nursing as well, particularly in this case with some of the effects of the traumatic brain injury. And then I just wrote here, consultation is teamwork. So when I was putting together, when Dr. MacFarlane, Conrad, and I were putting together this presentation, I talked with our rehab assessor, and one of the things that she emphasized that's so important is that it's not just a doctor-to-doctor transfer that we're doing. It's not a doctor-to-doctor question for consultation. It's actually team-to-team because rehab involves so much teamwork. And so if a patient is referred to our care and they haven't seen, physiotherapy or occupational therapy, it doesn't give us much information about how to create a rehab program, or really, knowing what their candidacy is to come over to inpatient rehab. So I just wanted to highlight that. So further into the case here, so with the report, so this gentleman is now post-admission day 30. Mobility-wise, there's barriers present. So agitation and also pain is limiting mobility in bed, transfers out of bed, transfers into wheelchair. As well, occupational therapy reports that pain is limiting their ability to engage in their own personal care. So they remain largely dependent on nursing for a lot of their day-to-day personal care and hygiene. And some of this as well has to do with the weight-bearing restrictions that they have through their upper body. Bladder is managed with a Foley catheter, but I put that in there too because that's relevant to us for mobility, because whenever there's lines or tubes attaching people to something else, it can affect how they move and transfer. So physical exam, at the time that this gentleman was seen on the orthopedics floor, he was alert and able to engage in the assessment, but didn't seem oriented to time or his situation. It was very easily distracted, so needed to be redirected as the history and physical exam were being completed. Positioning was painful, which made the physical exam difficult. And they could not really engage in any kind of ranging or assessment of their right shoulder. And there was a question of whether or not there were some skin lesions that might have been third-degree burns on both shoulder blades. And I put that in there because it's relevant. And also, as you can kind of see as I'm kind of walking over this first part of the physical exam, part of what we do in physiatry as well is surveillance. So when we enter a room or a patient enters our clinic area, we're looking at how they hold themselves, how they're moving. And these are also things that we use as part of our lens on the acute service as well, to see, kind of do a general scan of kind of things that might have been missed in the very acuteness and seriousness of a traumatic injury like this. As well, some other things that that were noticed while looking at kind of range of motion around the joints were significant ankle contractures. So this gentleman's feet were plantar flexed 25 degrees, which, 0 degrees is neutral. So 25 degrees is pretty significant, and also internally rotated. And I don't know if, if you stand on your toes and turn your feet in a little bit, it's not the most ideal position for balance, particularly if you've been in a hospital bed for 30 days. As well, a pressure ulcer was noted over the ankle, and this was stage 3, so a pretty significant pressure ulcer. Further on physical examination, the right leg weakness was examined, and it was noted that this patient had significant proximal weakness, so grade 1 hip flexion, and also knee flexion, extension, ankle dorsiflexion, and plantar flexion were all quite weak within the ranges available. So overall, kind of these findings, and I'm sure you're all familiar with this, but it highlights the risk of rest. So this gentleman who before the trauma was otherwise healthy, has been in a hospital bed for 30 days, understandably under acute care, initially ICU, and then moving to orthopedics. But this figure here just highlights some of the various things that we're seeing as we move through this case, from decreased mobility, but also highlights some of the other issues that come out within systems, and then contribute further to problems with muscle weakness, cognitive impairment, and engagement in rehabilitation, and also psychological and mental health issues that come out of that as well. And all of these things, the more they compound on each other, the more they make the long-standing morbidity for survivors of, morbidity of survivors of critical illness. And you can see the last line there shows, what that looks like after somebody leaves hospital and goes back into the community. There's new risks that they didn't have before they had a critical illness. This again highlights that. And it's just another nice graphic to just look at the different systems that are affected. And then I pulled this up actually from critical care resources, but I thought it was kind of nice because it went over just prevention of post-intensive care syndrome, which I'm sure you're all more familiar with than I am, but pretty much we had just reviewed there. But of course, what I was interested in here was this early mobility and exercise as a prevention of that litany of new morbidity that patients with critical illness experience.
Dr. Salsman?
Yeah.
Hi.
Hi.
Sorry to interrupt. Just wanted to mention that for the listeners, the case that we're presenting is an amalgam of a few people that I had on the floor. And so all of the things that you're hearing about are things that have actually happened. They're just shoved into one person. But one of the things that we run into with the post-ICU scenario is having been in bed for so long and the inability to sit up. Once we do get people sitting up, their blood pressure often tanks, and it takes us a few weeks before their blood pressure is able to sustain vertical sitting. And that will set rehab back by several weeks. So we'll have people who they sit up and try to use a urinal and then pass out or transfers to bathroom. They'll go unconscious. Reversal of circadian rhythm, things like that, will really set back a person's progress by quite a bit when they get to rehab. I'll apologize because I have not seen Dr. Salsman's most recent version of this presentation, but are you discussing the issues with staffing at night, Shanu?
Oh, no, I haven't, but it will be relevant about management of agitation.
So just to let those listening know, at the Nova Scotia Rehab Centre at night, we have one LPN and one RN, and that's it. So when we become a titch anal retentive about the medical stability of patients, it's because if we have more than one person who gets sick at night, we have no way of managing that effectively. We simply don't have the staff. So when people are quite ill, or if their O2 requirements are going up, we have great difficulty managing that with the staffing we have available. So bearing that in mind when we transfer people over, if that person needs a lot of nursing care, we don't have a lot of nurses. We have instead lots of OT, PT, things like that. So please bear that in mind when you're doing your referrals.
Great, thank you. Yeah, so I just added this one in as well too, because I was talking about the post-intensive care syndrome, COVID-19. But another thing that is always pretty top of mind in medicine is frailty. And just looking at the impact of pre-existing frailty on outcomes after minor and major illnesses. And just the relevance for our aging population, and really for for predicting what kind of outcomes are occurring and how we can intervene in order to help have better outcomes for people who suddenly experience unexpected critical illness. Also wanted to highlight the work of a colleague, so Dr. Rob Green, who's on the call today, and his team, that they did some great work here to highlight the importance of an early mobilization program in trauma patients in the critical care unit. And from that very nice study, they noted that there was a decrease in hospital mortality and ICU mortality. And from this work, I was really interested in working with Rob in order to see what kind of role physiatry can play in facilitating an early mobility program, because I really do believe that we can improve patient outcomes and decrease length of stay the more involved we are. So back to the case. So when this patient or cohort of patients was reviewed, and as we do, whether it's just an inpatient kind of medical consultation or preparing a patient to be ready for transfer to inpatient rehab, there's a number of things that we review and make recommendations for the team. So here, with respect to agitation, looking at, so assessing as to what the cause of that is, and diagnosis of traumatic brain injury, making sure that there's nothing else going on there, so recommending an MRI to rule out a watershed infarct that could have been from hypotension or an incidence of cardiac arrest. And then looking at the agitation that's present and what's causing it. So this is, we call the ABCs of agitation. So antecedent, what the behavior is, and then the consequence of that behavior. So then taking agitation and looking at antecedents, we look at that framework and look at what the state of cognition, mood, learning is in this patient, how bowel and bladder dysfunction might be contributing to that, specifically in this case, and also the pain that the team is reporting. So for management of agitation, the recommendation was to move this gentleman to a private room to reduce overall stimulus that can be leading to agitation. And improve their orientation. So putting things in the room that orient him to time, because that was the thing that he was struggling with. So calendar displaying the date, or writing on a whiteboard what the day is, what time of day it is, and also the circumstances for them being there, maybe their nurse's name. So giving them a sense of orientation to the day and daytime and nighttime orientation as well. And then removing other sources of agitation. So it was found that this patient had constipation, so bowel clean out, and then starting regular bowel regimen, removing the Foley, and then trial spontaneous voiding, and overall pain management. Pain management, so the pain that could be adding to the agitation would be from the contractures at the shoulders and the ankles, and also skin breakdown, so areas of the pressure injury. The right leg weakness is also limiting their mobility and limiting their independence. So what is the cause of that? It was suspected to be peripheral neuropathy, and electrodiagnostic studies did confirm this. And this may have been due to the retroperitoneal bleed or to intraoperative positioning. However, it did explain the severity of the proximal weakness, and electrodiagnostic studies are also important too for prognosis as to what's the potential for the recovery of this patient to regain strength in that leg. For pain management, in order to help progress range of motion and movement at the areas that were contracted, orthopedics was asked to provide some weight-bearing status updates and to clarify upper extremity restrictions, plastic surgery to manage the wounds, and given that they're in inpatient service already, APS to reduce the opiates, which can also further affect agitation because of decreasing orientation. And addressing the nerve type pain that he was experiencing with gabapentin and Sativex, which is a cannabinoid spray. The other important thing that we often are talking to people about, whether they're inpatients or outpatients, is treating pain prior to therapy. So pain management is here with a goal, so not just of decreasing pain, but also to decrease pain in order to engage in activity. Prescription of orthoses and bracing to reduce ankle contracture. Here I have a picture of an ankle foot orthoses, but you can also use a splint in order to maintain that position from the plantar flexion to a more neutral position. And for the wound, given that they're spending a lot of time in bed, and we don't want that stage 3 ulcer to get worse, an offloading boot to address the pressure ulcer. So then the question is candidacy for inpatient rehab. So we'll scan through the admission criteria, but overall, now that he has improved agitation, so less irritation because of the recommendations, more cooperative with engaging in physical therapies, it would be a better time for him to come over to the rehab because he'd be able to be directed in the intense physical therapy programs that we provide. He still has significant pain and limited range of motion in his shoulders, but some further investigation into that and trialing some other therapies at rehab might be helpful. The discharge location, it's nice and needed that the team who's transferring them to rehab has a plan for where they would be discharged to after their inpatient stay. It remained unclear, and really this was about just having appropriate supports in the home, both for his traumatic brain injury and also physical impairments. So upon reassessment, he was transferred to the Nova Scotia Rehab on post-admission day 60. So I'm going to go through these relatively quickly because I think they're just kind of a lot of notes, but please stop me or just add any questions in the chat if you have any specific to admission criteria. But generally, I will just kind of review the ones that I think kind of are highlighted by this case. Overall, a patient needs to want to come to the rehab. It's pretty important that they want to engage in physical therapy to come over to an intensive rehab program. Overall, we want people that are complex, and that might sound obvious to a group that works with complex patients, but it's not unusual for us to get a consult and say, oh, can this person come over just because they're otherwise not very motivated? And if we send them home, they might not go to physiotherapy. We need kind of a really we need a lot of different functional challenges for them to really benefit from having a bed at the rehab center with all the different members of our interdisciplinary team. And also the potential to make functional gains. So kind of further to this, that would be, you know, a patient that doesn't have a prognosis that would limit them. But, you know, we do have patients that come that have progressive neurologic disease, and that's fine, because there's usually always something we can do to help people function better at home. They need to be medically stable, just because we do not have the resources to support vital functions, such as we don't have in-well oxygen, and if somebody still has a lot of things that they're getting treated for or being transferred for, they're not able to engage in the regular rehab programming. So there's not a real big, there's not good use of the rehab bed. They need a certain level in order to be able to tolerate the level of rehab that we provide. So sitting tolerance of at least 1 hour, 2 to 3 times per day, and being able to participate in 2 hours of therapeutic intervention per day. It's pretty standard that patients attend physiotherapy for 1 hour in the morning and 1 hour in the afternoon. On top of that, they might go to occupational therapy for 1 hour. On top of that, they might also have speech language pathology, or meet with a dietitian or social worker or neuropsychologist. So it's a pretty busy day, and patients need to be ready to really take advantage of the resources that we have at the rehab center to benefit. And then also ability to learn. So that's relevant to this case. So somebody who has an identified cognitive impairment, and then also is able to follow in the level of instructions that we need them to participate in physical therapies. It doesn't have to be perfect, but some ability to engage and retain the things that they need to do day to day.
It's sort of to underscore that a little bit, Dr. Salsman. It can't be Groundhog Day with the patient, because otherwise we don't go anywhere. If the person's got a very poor carryover, you end up having several weeks of Groundhog Day, and with the anticipation on the part of the patient and family that rehab's going to make it all better. And we can only work with what can actually be worked with. So if you have zeros for strength, we can't make that strong again. The other thing is the patient really does have to want to come to rehab, because we are asking people to engage in fairly intensive training. They have to be willing to engage in occupational therapy, so wheeled mobility, ADLs, positioning, transfers, as well as physiotherapy. So there's the onus is very much on the patient, and if the patient cannot take up the onus, then that becomes a big problem, and they end up staying at rehab for a very, very, very long time with no gains made. Sorry to solve.
Yeah, and you know, when I was reading through these, you know, admission, whenever I look at these admission guidelines and, you know, exclusion criteria and stuff, I just want to be clear that, you know, and we're not like, oh, you know, we don't want to take patients. If your patient is not ready, we don't want to take them too early, because we'd rather take your other patient who's ready. So, you know, we have all these resources, and we get very excited about using them to mobilize people well. One of the things, you know, on here is just about restrictions and precautions clarified. So having somebody come over who's going to be non-weight bearing for the next 6 weeks and can't engage in therapies, it's kind of a waste of the patient's time, and also that bed during those 6 weeks could be used for another patient that could engage in therapy. So it's not like we're saying no a lot. It's just that we really are excited to apply things, and it can be kind of frustrating when we have somebody who's just kind of you know, taking up a rehab bed when they could be maybe at home, which is a great place to rehab, or continuing with other therapies in a less intense environment. Exclusionary criteria. So basically, we just, as I said, that it's consultation is a kind of a team sport. We don't take people directly from emerge, ICU, or IMCU, because they need to have engaged in some therapies for us to have an idea of their rehab plan. We can't just kind of blanket apply things on people. Knowing what they can do allows us to make it realistic for the patient. again, I kind of said before about just interventions or treatments that consist of active participation. We have a number of patients that are on dialysis and they go 3 times a week, and that's fine, but we do try to change those times so that it doesn't interfere with their therapy. And then ongoing investigations or other medical management. The details of that would be discussed with whoever's reviewing the admission. Behavior can be an issue, as it was with this case. And so, just taking on the recommendations that the rehab team will make in order to improve something like, behavior or agitation is good. But again, we want somebody who can engage both physically, cognitively, and behaviorally with the rehab program. And a primary diagnosis that's psychiatric would not be reasonable. And I say this because sometimes there are referrals for patients who have what's called functional neurologic disorder. So this is a disorder that is psychiatric, but is somatic, if you're kind of familiar with that, more of that terminology, where it manifests itself in physical impairments. So that is not, rehab is not the best place to rehab those people. Palliative, we do have palliative patients that come over, but prognosis is important, and we usually try to get them home as soon as possible, understanding that they're palliative. Many of my ALS patients will come for a short admission, maybe for an intervention like placement of PEG tube, so it's not totally exclusionary, but just overall, we don't just palliate people, and rehab is not really a place for people to pass away either. A palliative care bed would better serve them. Because of our nursing issues and also just the physical demands and need for equipment, so ceiling lifts and things like that, we do have restrictions as to what they we do have expectations as to what they can do. So no more than a 2-person maximum assist. We just don't have the manpower for more than that. We just don't have the ability for one-on-one nursing and any kind of parental feeding. We can't accommodate, unfortunately. The other thing I put this as a different slide because it's exciting. What's great is you don't have to come to a rehab hospital if you can do it in the community. And that's great because you get to live in the real world of your home environment, which gives us ton of information on how you're functioning. And as long as you have transportation and it's reasonable travel distance, it's great. We actually encourage people to go home on the weekends if they're safe to do so and it's possible, because exploring your own environment gives you a real world testing ground for your new normal and progressing through the goals that you want to achieve. So within inpatient rehabilitation, we focus on, and in this case, mobility and increasing independence with activity of daily living, as well as continued management of agitation and memory with TBI and discharge planning. So just to kind of finish this off, because I do want lots of time for questions. Mobility was limited because of contractures and weakness. Some different interventions. So a wheelchair is also a form of mobility. Transfers were difficult, hoping to improve mobility, and we have a nice warm pool in order to do that in. This was unfortunately delayed for this gentleman because of open wounds, so this highlights the importance of getting right on wound management before they come over to the rehab. There's a number of things that come out from just having that prolonged rest that then affect how quickly they return to mobility or independence with activities of daily living. How quickly their rehab moves along. Also, we have our podorthics team, and unfortunately, because the plantar flexion contracture was just didn't progress much away from that 25 degrees of plantar flexion, they built a shoe that brings the ground to him rather than trying to bring his heel to the ground. He did progress with increasing independence with activities of daily living, but still very difficult with shoulder pain and decreased range of motion with contracture, as well as he was moving more. And this happens as people move more, they identify new pains. And unfortunately, there was finding of non-union of a unknown scaphoid fracture with the beginnings of AVN. So that our occupational therapists created a brace for support in order to continue moving forward with transfers and activities of daily living. Agitation, so that had improved before he came over, but our team is quite familiar with redirection of patients that are easily distracted, and also monitoring for impulsivity, and being able to interact with patients who are irritable. Unfortunately, the MRI did show watershed infarcts, but also some white matter changes. So knowing the full picture of what's going on with regards to brain function, we use, there's regular agents that we use for agitation, and in here, propranolol, sertraline, and some quetiapine at night for agitation and irritability. And also managing secondary risk factors with regards to this, the history of infarcts, and managing in a private room, so not in a ward room with other patients. Discharge-wise, this was complicated, but we have a wonderful social worker that looks at what is truly reality for these patients in going home, with regards to sources of income and funding for equipment and renovations in the home. Outpatient occupational therapy and physiotherapy follows, as well as there's an outreach team for ABI that can come and check in on the home. And how they're functioning. And then at this point, with somebody with that significant effect on cognition, driving and return to work was discouraged. And if the patient does not seem to be in agreement with that plan, a letter is written to the DMV to make them aware, to keep everyone safe, including the patient. So then he was transferred to home hospital, which was elsewhere in Nova Scotia at post-admission day 90. So he's full length of stay, 3 months in the hospital. We have outpatient follow-up. So he followed up virtually as he lived a distance away from Halifax. And the physiatrist continues to look in as to what impairments continue at home, how they're functioning, pain management. And also the long-term effects of having a traumatic brain injury and a prolonged stay in hospital. So continually checking in and trying to optimize their overall function cognitively, physically, and with pain management. Driving and return to work at this 3 months post-discharge still was not appropriate. All right, so we have 15 minutes. I just wanted to just kind of quickly, and this one for real, I'm going to do quickly. These are rehab emergencies, and I wanted to talk about this because it was a question from your teams about management. Overall, the two that I picked, autonomic dysreflexia and agitation, it's important to recognize what the signs are. There are so many resources for this. The best one is the Paralyzed Veterans of America. I have a picture of the handout. But autonomic dysreflexia is something that's often not recognized when patients attend the emergency department, and not recognized in patients with spinal cord injury. It rarely occurs if patients have, or if persons have spinal cord injuries below T6. The reason for this is that there's an opposed vasodilation unopposed sympathetic outflow below, and then a lot of vasodilation above, so a lot of increase in blood pressure above the level of the lesion, and that increase in blood pressure puts them at risk of bad things like stroke. So the baseline of a spinal cord patient, their baseline blood pressure is much lower, usually 90 to 110, and an increase of 20 or 40 milligrams is significant, or sorry, 20 millimeters of mercury is significant. They may have symptoms, they may not have symptoms. It may just be that a nurse records that they have a high blood pressure and the patient reports that, well, that's unusual for them. I usually run, you know, at a systolic of 90. So it's important to identify, so based on the blood pressure, what, if there are associated symptoms, but, you know, they don't have to be there for somebody to be having autonomic dysreflexia. If present, they'll feel a headache, they'll be sweating, so vasodilated above the level of injury, they'll and flushing, and there'll be vasoconstriction below the level of injury, so paleness, coolness, goosebumps. They may also have blurred vision, nasal congestion, and they may tell you that they feel this overall sense of doom. And they may actually be, and usually are, very familiar if they've had autonomic dysreflexia before, and they will tell you, this is, I'm having AD. So sudden significant rise, 40 to 20 millimeters, with bradycardia, or I keep saying millimeters, but Annie, you know what I mean, bradycardia, and they're also at risk because of this for cardiac arrhythmias and conduction abnormalities. So again, those were symptoms there, above and below the level of the spinal cord injury. And common causes, the most common is a full or distended bladder. So that is a bladder that is overstretched or irritated. So the first thing you do is look for what could be causing that. If they have, do they need to be catheterized? Do they have a catheter in? Do they have a UTI? Next is bowel overstretch or irritation, which can be from constipation, and then other what we call noxious stimulus, so areas of pressure like a pressure sore, sitting or lying on something hard. Some people can get it from having a hot laptop on their lap. Some people can have it because there's something in their seating that's causing pain. They might have, you know, because with the loss of sensation in their below the level of their injury, there can be things that are applying pressure or pain that they don't feel. So other things, skin, ingrown toenails, check for those. Burns and sunburns, that's definitely a thing we've seen, or bug bites, and tighter restrictive clothing. There's other things as well to look for, and we've definitely found some different varied reasons for a patient having continued episodes of autonomic dysreflexia when they are on the inpatient floor. Overall, for management, check the blood pressure, sit them up 90 degrees, loosen clothing, keep monitoring their blood pressure, and you need to do this over the next 2 hours to make sure that they're actually going in the right direction to return to their baseline blood pressure. Survey for triggers, as we discussed. And then there's some medical management that can be done as well. If you're going to catheterize, or if you're going to do a bowel, taking out some of the fecal matter to relieve constipation, it's best to use some lidocaine initially in order to decrease sensitivity, even if they don't have sensitivity at that, even if they don't have sensation at that level. Medically, this is a really nice overview that came from BMJ, and then this is a picture of the Paralyzed Veterans of America guideline, which is really just the standard. So I direct you to really the PVA resource, because it has everything in there, including first-line treatment with nitro paste, and repeating this every 10 minutes until you can get their blood pressure back down. But if it remains elevated despite that, above 150, captopril, and then again repeating that. Avoiding beta blockers, because it will just increase their autonomic dysreflexia symptoms.
Dr. Salsman.
Oh, sorry, yeah.
Sorry, just to mention, one of the reasons that we get fairly stressed about autonomic dysreflexia is that, in addition to the cardiac consequences, you're shoving so much more blood up proximally that your CPP is going up quite a bit, your perfusion pressures within the brain. So we will often see people who become encephalopathic, stroke. A lot of white matter change is seen in people with recurrent AD, because you're having those spikes of increased pressure. Yeah. So your risks of eventual stroke do go up dramatically. So you're dealing with what's a fragile brain, because a higher level stroke probably means that the brain got shook too. And so the risk of encephalopathy, seizure, stroke, MI, all of that goes up dramatically in autonomic dysreflexia. And so that's why we tend to be fairly aggressive about its management.
Yeah.
Thanks.
Yeah. Good. Very good points. Yeah. Agitation, really the point that I wanted to make here was that what we start with is overall making sure the patient is safe, and then looking at our ABCs and ruling out what is causing, so what the antecedent is, and then approaching the patient initially with non-pharmacologic management. So again, think about the patient who maybe is not oriented, maybe doesn't know who you are. You know, you want to be calm, use simple directions, and redirect their attention, and be patient with that process, in order to make sure that they're okay. So getting a history from nursing and also from them. Non-pharmacologic for agitation, we talked about in the case moving a patient to their own room, so decreasing stimulus, making sure they're safe, so less risk of fall with a bed on the floor. Window covering, that is actually less stimulus. It seems to be, not orientating them to the time of day, but less light stimulus. Good room to move so they can walk around the room or pace if they need to. Have a therapeutic attendant so that there's somebody there to alert the team to make sure the patient is safe, and avoiding restraints in general. There hasn't been really good evidence for using those, although I think there are some times when they are used, but we do not use them in the rehab center because we move through a non-pharmacologic treatment and then pharmacologic as needed. Some of the ones in the case are highlighted here. Propranolol, quetiapine was another one that we had noticed. Ritalin for improving attention, but not, we don't give them benzodiazepines. We don't give them Haldol. That's not practice. And we have patients with recurrent agitation again and again and again because of traumatic brain injury or anoxic brain injury. And just to emphasize, our first approach is non-pharmacologic, because during their rehabilitation, we also don't want to set them back with regards to cognition as well with a bunch of sedative medications. So that's me. So we have about 8 minutes for questions. So I will stop talking.
Thank you. That was great. Certainly opened my eyes to a lot of things. I had no idea that there was only one registered nurse and one LPN working at the rehab overnight. That's crazy.
Yeah.
Given the number, oh, sorry.
Sorry, go ahead.
A number of our patients are fairly significant vasculopaths, and many of the people we have coming from the ICU are medically very complex rather than traumatic. So the medical demands of the patients we have on the floor now have increased fairly significantly.
Absolutely. I'm just looking at the chat box. I don't see any questions in the chat box or any questions in the questions. There are a few people that had their hands raised. So I don't know if anyone who had their hand raised wants to just quickly put their question into the chat box. That would be great. Or maybe just comment and I can try and unmute you so you can ask your question in person. Oh, there is something in the chat. In the patient you presented and in general, do you think that earlier assessments by rehab is a good idea?
Do you want to answer that one, Monique?
Sure. I think yes. In the case of some of the folks that I see that are getting onto the floor, some of the things like ankle range of motion, the beginning of pressure ulcers, can be addressed very, very early on by making suggestions with regard to surface, the surface that the person should be on. The person in this case with the mild appearing presentation and GCS on admission was 13, 14, not so bad, so you wouldn't think brain injury. We're able to look at that person and sort of get the flavor of what's going on and go, no, this is a brain injury. Let's get right in on that right now. and try to moderate the stimulus of the person in question. Let's look at the bed surface. They're on bed surface. This person was non-weight bearing, and so the ability to weight shift was going to be impaired. When somebody's been in a polytrauma, there are scrapes and lacerations everywhere. And so you've assessed those and you're expecting to see those. So we have had somebody come in who had third-degree burns, but because of the circumstances of the polytrauma, those weren't recognized in the moment because of all the other skin damage that had happened. So the burns, a piece of the person's ear fell off in therapy because of charring. So, but there's so much else going on with this person that small third-degree burns are hardly the thing you're thinking about when you're trying to keep them alive. So these are the things, the details that we'll look at, because you guys are the experts on keeping hearts beating and viscera operating. That's not our wheelhouse, and we will happily defer all of those things to yourselves. The little things like what's going to get this person moving. Is this person's elbow flexed regularly? Because if the scapula isn't moving, the shoulder's going to freeze. If the elbow isn't moving, that person has now developed a Barbie arm. And if you've ever tried to pretend that your Barbie was drinking something, you'll notice hand doesn't go to face. So things like that are the details that we'll be able to see, the trouble spots that could occur that we can advise you on while we're dealing with the things that could happen and making suggestions along those lines so they don't become a problem that delays discharge later. You guys are dealing with the very important detail of keeping them alive, and we can deal with those ancillary things that are going to become a problem later. Does that make sense?
Yeah.
That absolutely makes sense. I don't see any other questions, so I just want to thank you two for taking time today to present as part of our webinar series. It certainly was informative and just an area of medicine that I'm not particularly familiar with, and it was definitely wonderful to hear about.
Yeah, thank you. And I really appreciate the opportunity to talk with this group, because my interests and mine and Dr. MacFarlane Conrad's interest in trauma rehab and delivering the best care to all our patients. And, you know, if in the future you have any questions, please do not hesitate to contact me. I had another slide that had my email on it, but it's not difficult to find. It's just suzanne.salsman@nshealth.ca. And you can page me. That'll go to my cell phone, and I'm really happy to answer any questions that you might have as we kind of explore increasing the role in physical medicine rehab with trauma patients.
Right.
Oh, sorry, Brian, just to mention, interestingly, there's some residents that will have rotating through from other centers in Canada and in the US, and apparently having a physiatrist attached to trauma centers is really quite common, so that discussion can start happening immediately. Things like discharge, you know, you're in now, but you're going to leave later. What's that going to look like? And to have that sort of lens of, we're dealing with the now, but the later is going to happen, so let's start dealing with the later now.
Certainly, and I think that's come up in discussion quite often with our trauma consult service, just identifying those patients who may benefit from just a physiatry consult and eventually a rehab consult.
Absolutely. We look forward to having those discussions. Even if it's answering questions over the phone, we're thrilled to do it. We're very happy to help you problem solve.
Wonderful. Well, thank you very much, and I'll let you guys get back to your day.
Thank you. You take care.
Thanks.
Thanks
Bye.
so much.
Bye.